Okay, it's very quiet, so I think maybe it's time for us to get started. Welcome everyone, and good morning. I'm very excited to see we have so many people in this room. This room seems empty no matter how many people are in here. So we are actually quite a few people, and we also have quite a few online, so that's very good. Today we're focused on the theme of equity. So it's a very, very important theme within civil registration and vital statistics. And this specific session that we're in today is on death registration and mortality statistics. And I know you've all looked at the program, so you all know who the speakers are, but just a little bit extra. We have 5 excellent speakers here, and I have placed myself in the middle, which is fantastic. I'm really, really pleased to be surrounded by quite a variety of topics, but focusing on who are left behind, how can we ensure more complete systems. As we are moving towards universal registration in many countries, it's become increasingly important to understand who are the ones who are left behind. And this is really what we're focusing on this session. We are looking at who are the people who do not have their deaths registered, and also what does that implicate for data. So we have 5 excellent speakers from Indonesia, US, we have Sri Lanka, and we have Bangladesh and Vietnam. So quite a lot, predominantly from our Asia Pacific region, which is my home region. So I'm very happy to see that, of course. And I know that you've all been here for several days now, so you kind of know the drill, but each speaker has 10 minutes, and then hopefully we'll have a few minutes for specific questions to that speaker. And at the end of the session, when all of our amazing speakers have finished their presentations, we will have hopefully a little bit more time for questions and answers. So please, remember your questions, write them down, and make sure that you ask them later. And I would also like to encourage our participants online to write questions in the chat box, and then we'll make sure to get to those as well. So we have 5 presentations, and we will start off with our presentation from Indonesia. And we have Desta here, Desta Indriyanti Antika. Sorry, I cannot say that. Indriyantika, is that correct? Sorry. My name is also very difficult to pronounce, so it's okay. And she'll be presenting on spatial analysis of the completeness of death registration in Indonesia. She works with BPS Indonesia, which is the statistics office of Indonesia, and it's one of the largest statistics offices we have in our region. She specializes in population and labor statistics, and particularly on CRVS, which also means that I've had the pleasure of interacting with her multiple times. She focuses on strengthening systems, improving data quality, and supporting evidence-based population policies. So over to you, Desta.
Yeah. Thank you, Tanya. So good morning, everybody. I'm Desta from Indonesia. So this study contributes to strengthen Indonesia's CRVS system by analyzing spatial inequalities in death registration and identifying key factors to support more targeted policies. Yeah. So, like many developing countries, death registration in Indonesia is still low. It is only 56.7% in 2023, and this percentage is also unequal across region. For example, in Jakarta, the capital with more advanced economy and infrastructure, completeness reached 100%, while in West Papua, a more remote region, it is much lower at only 9.2%. Low and equal completeness of death registration makes it difficult to produce accurate mortality statistic to monitor health program and respond effectively to crises like COVID-19. Therefore, there's an urgent need to improve death registration so that it's become more equitable across region. To improve death registration, previous studies suggest identifying cluster of areas with low registration for targeted intervention based on their characteristics, as well as high-performing areas that can serve as best practice. Local level intervention are also essential, meaning that specific action are needed at each subnational level. Therefore, however, evidence on this is limited, as most studies rely on qualitative approach. Therefore, the study aims to, the first one, to identify which area have good performance and which still need intervention. And the second one, to identify the factors that support and hinder death registration in each province. So to identify the best practice area and those needing more intervention, I use quantitative spatial approach. The first one, morons, the second one, Getis Orchi, and the third one, local indicators of spatial association, or LISA. I use data on completeness of death registration in Indonesia year 2023, calculated by Statistics Indonesia. So, how are the results as well as the discussion? The first one, let's look at the distribution completeness of death registration descriptively. The completeness of death registration in Indonesia increased from 34% in 2019 to 56.7% in 2023. This improvement is also seen across provinces, as shown by the darker color. However, there are still large differences across regions, as shown by the different shades of blue. Areas with darker color, mainly in Western Indonesia, which have more advanced economy and better access to health and civil registration office, show better performance. Meanwhile, area with lighter blue, mostly in Eastern region, which is more remote area, still need improvement in death registration. This result indicates that high-performing areas tend to be close to each other, forming cluster that can serve as best practice area. Similarly, low-performing areas also cluster each other and can be targeted for intervention. So the clustering of areas based on death registration performance is also confirmed by statistical tests. But although the maps show a clear west and east pattern, the statistical results show that the clustering in each province level is relatively weak. This means that high-performing provinces are not always close to other high-performing provinces. They can be near to lower performing areas and vice versa. So we need to identify specifically which areas can be considered as best practice and which need intervention. Based on the statistical result, the best performing areas are Jakarta, Yogyakarta, and Central Java. This area have good performance with completeness 100% in Jakarta and 94% in Yogyakarta. These three provinces show good practice. For example, in Jakarta, health facilities and civil registration offices are connected, so death certificate can be issued directly at hospital, and then death registration can be done online. Then there are local regulations that mandate death registration. On the other hand, areas that need intervention are unfortunately not statistically significant. However, this doesn't mean that low-performing areas doesn't exist. Instead, it suggests that under-registration may happen at smaller geographic level, such as maybe district or city, so it is not detected at the provincial level. Therefore, further studies are needed. And weak clustering also indicates that death registration is a local issue, requiring local and context-specific intervention at the provincial level. So it is important to identify the enablers and barriers in each province. To do this, I use geographically weighted panel regression. The dependent variable in the completeness of death registration. Then independent variables including ICT access to represent access to information, awareness, and ease of reporting death. Then COVID-19 crude death rate to capture system strengthening during pandemic, then local regulation to represent policy support and coordination in death registration. And also there is health worker, informal employment, gross domestic product per capita, and aging population. So the analysis covers 34 provinces from 2020 until 2023, and the data comes from BPS Statistics Indonesia and also web scraping. So now we move the result and the discussion in the second research purpose. But before that, please note that the colors don't represent the heat map. They only used to align the map and the table. So this map is a summary of the factors affecting death registration in each province. It's shown that it shows the top 3 variables influencing death registration in each province. For example, let's stick to provinces in the low registration performance in eastern Indonesia. The first may be West Papua, as you can see in the row 10. The main factors that affect death registration in West Papua are COVID-19 CDR and local regulation. This shows that better reporting system during pandemic help increase death registration. For example, deaths were reported through various channels such as community leaders and then health workers, and there's a routine reporting from health facilities via online system to Ministry of Health. And then local policies such as giving financial support to poor families after a death also help improve registration. This means that to improve death registration, the government can reuse the effective reporting system from the COVID-19 period, strengthen community and healthy facility reporting, and apply suitable policies, including incentive. And second one, maybe we can take East Nusa Tenggara, or you can see. You can see in the 5th row. So the main factors are COVID-19, CDR also, and then ICT access and environment employment. In East Nusa Tenggara, more than 74% of workers are informal, and they are less connected to administrative system and health services. So the lack of incentives such as social security of death benefits and limited income reduce their motivation to register death. ICT access also lower compared to other region. It is only 75% over there. This suggests that strengthening outreach for specific groups and improving digital literacy for better access to information need to be implemented. And then, the same interpretation to other region. So to recap, there's our key takeaways from this study. The first, death registration is improving, but regional gaps remain. High areas are close together, while low areas are disparate or occur at smaller level. Then Jakarta, Yogyakarta, and Central Java can be used example of good practice. Then improving death registration require local level intervention. Then each region has different factors, but in this study, most factors improve death registration except informal employment and economic condition vary across region. So to improve death registration, several steps can be taken. The first one, digital access needs to be expanded, especially in remote area in Indonesia. This will help people access the internet and administrative information more easily, while also improving their awareness and understanding of the death registration. Digital campaign can also support this effort. Then reporting system should be more inclusive. This can be done by providing multiple reporting channels such as website or involving community leaders and health workers, especially to capture deaths are not recorded in the system and deaths that occur at home. And the second one, the implementation, coordination, and accountability need to be strengthened through local regulation. This includes identifying effective policies, such as providing death benefits to low-income households, as well as mandatory death registration. Then, in addition, successful local innovation should be identified and can be formalized through regulation. And finally, health and civil registration system need to be better integrated. An integrated system should allow death notification from health facilities to be directly connected to civil registration. It should allow death certificate to be issued directly at health facilities. So to support this, improving the capacity health workers in death registration also needed. So because there is a limitation of my study, I recommend to future research to conduct district level analysis of death registration completeness to identify under registration pockets and examine death registration system developed during COVID-19 as the best practice. So before I close it, I would like to acknowledge my colleague Wida from BPS Studies in Indonesia and also Lily from Deakin University as co-authors. I also extend my gratitude to ESCAP and ECHA for their support. In addition, this work was developed as part of 2025 CRVS Applied Research Training Initiative. So with this registration, it is expected that everyone has equal access to protection and social benefit. Yeah, saving life by counting death. Thank you.
Thank you so much. That was really, really interesting. And I think, I don't even know where to start. I really love how you talk about access to registration. You also focus on incentives, and that's one of the troubles we always have with death registration. How do you actually create incentives for registration? So it was really nice to hear about that as well. And then you touched on a couple of things that we haven't heard so much about this last few weeks, last few days. You talked about informal workers and the impact on that for registration, which I think is definitely an issue we need to look more at. So it was very nice that you had that in your very, very, very interesting and very a thorough presentation. And it's always nice to see maps. I don't know, everyone, it just makes it so much more tangible when you have the maps and you can actually see the registration levels and so on. So thank you so much. I don't know if anyone has any specific questions that they would like to just clear up before we move to the next presentation.
Thank you, Desta, for a wonderful presentation, and I also love the maps. So my question is regarding your recommendations that you mentioned that during COVID-19, you saw that the number of death registrations improved. So do you think that it's because of the total number of deaths increased in COVID-19, or maybe because there were the total figure was very high? Maybe it could be the reason that it looks as if the mortality rates increased, or do you have data regarding the other deaths from other causes that was increased as well? Thank you.
One more quick question. Amir?
Thank you, Desta. Really excellent presentation. And thank you for saying that as future research, you are looking at the district level analysis. So I was just curious whether before doing that analysis, whether it would be worth engaging the civil registration authorities in terms of understanding what type of analysis would be helpful to them. And also the point that Tanya made in terms of the informal workers. I know this may go a bit beyond the stretch, but like, again, having qualitative studies to validate some of those findings and which can also inform what type of interventions can then be targeted. So thank you.
So Mira has just given you a research program for the next 10 years. Thank you, Mira. So there were two questions. One was about the experiences from COVID-19, and I think the question was really, is it because there were more deaths, or was there something different about the way deaths were registered during that period? And then the second question was whether it would make sense to engage with Moha to get a better understanding of some of the qualitative aspects and what is also needed for them to really improve the system. And then, yeah, lots of ideas. So there were several questions in Mira's question. One was about whether it would make sense to engage with the civil registration authorities or with MOHA to better understand what their priorities, what they need to understand in order to improve the systems, and whether how you can support that. And then also, yeah, support for further district analysis, and maybe also a recommendation to do qualitative work to understand some of these patterns, including the informal workers' issues in more depth. So yes, a full research program for the next 10 years from Mira to you. Yeah. There you go. Do you want to respond to these questions quickly? Thank you.
Okay, for the first question for Amna, actually when we calculate about completeness of death registration, we use numerator and denominator. So when we use the denominator, we also consider the number of death regarding COVID-19. So like another in 2020, 2021, 2022 until 2023, we input all the number regarding to including the death of COVID-19. So I think it is not because there is more number in death in specific event like COVID-19, because we have considered it in the denominator. And then thank you for your suggestion about the next research. So actually, I want to inform you all, maybe it is really interesting to you, that I'm doing my research too regarding to completeness of death registration in district. So I will estimate it. I'm doing it right now, so I will be happy to share it if it has done. So yeah, thank you.
Thank you so much. So in the interest of time, we'll move to the next presentation, but we might have some time later as well. And it is actually a perfect bridge because the next study is qualitative. So we're very lucky to have Alicia here, who is a Senior Research Program Coordinator with the Gender Equity Unit at the Johns Hopkins Bloomberg School of Public Health. So that's been a long travel here. Thank you. Their work examines how gender shapes access, inclusion, and inequalities in death registration, legal gender recognition, and civil registration among refugee populations. And this research is actually focusing on 3 countries, and the overall topic is strengthening female death registration insights from 3 countries. And Alicia, did you get the clicker? No, you did not. There's the clicker for you. So we will move on to this next presentation. Over to you.
Hello. So yes, I am Alicia Hancock, coming from the Gender Equity Unit. If you're wondering where those 3 countries were, they were Solomon Islands, Tanzania, and Bangladesh. The research was led by in-country partners, so I want to thank them first and foremost. They are coming from Solomon Islands National University, CRVS International, and BRAC University James P. Grant School of Public Health. So they were the leaders of this research. We just did the cross-country analysis. And I also want to give special thanks to our partner organizations within the Data for Health Initiative who are vital to this work. So a little bit about the background. So existing CRVS literature identifies aggregate gaps by sex, but it offers limited insight into the reasons why households deprioritize registering female deaths. So these graphs behind me highlight these gaps for each of the countries of interest. So if you're looking, the gray lines at the top are male deaths that are reported, and the orange or yellow lines at the bottom are female deaths. So we can see across all 3 countries there are significant gaps, with the widest gap being in Solomon Islands and the lowest gap being in Tanzania. And these are sourced from the WHO Inequality Monitor. So what we did in this research, we're trying to describe barriers and facilitators to female death registration at a household level, and then consider potential mechanisms for improving female death registration. So how did we do that? We conducted a qualitative study across 100 households, so 100 interviews with these household members to identify gaps that they could see. And across all 3 countries, what we tried to do was stratify by high and low death registration areas, urban versus rural areas, and also whether the deaths were registered or not. So we tried to get equal amounts of each in each country. So what we did is we analyzed the transcripts that came from those 100 interviews by first creating a code book based off of the interview guides and also the socio-ecological model. We then conducted intercoder reliability testing, which sees how coders in each country look at the interviews and interpret what's being said. So seeing if they have the same ideas and themes across each coder. And then what we see in our results, ta-da, are key barriers. So from the families, we saw that if an individual had limited understanding or awareness of what female death registration was, they would not pursue it. We also saw at an interpersonal level, so within the family, there was a gendered asset gap. So if a female did not own property, if she did not have a formal workplace, her death was not registered. And beyond that, the community then had low perceived value of female death registration. If the family sees no reason, why would the community? And then at an institutional level, this persisted. So when there's no incentive, but there are high barriers, if you have to go to a place that is far away, if you have to pay fees to get there, or if you're harassed when you go to a registrar and they ask for additional fees, you won't register. There's no incentive to. And these are some of the key highlights from barriers. Oh, from participants and the identified barriers that they had. So the top gray highlights a key barrier related to community norms surrounding gender-based violence and a hesitancy to register deaths that were sensitive causes. This was especially highlighted in Solomon Islands, but it was mentioned throughout the other countries. The green on hopefully what is your left is highlighting, let's see, female deaths being regarded as administratively unnecessary. So again, when the deceased did not own property or have entitlements that were employment related, there was no reason to register the death. And then the bottom gray highlights that the cost and distance associated with reaching these registration offices were huge barriers. These kinds of barriers to access were especially high when a female family member was attempting to register the death of another female. So we often heard that if a female was trying to go to register a death, she would be told to come back with her husband later, or she would be harassed to the point where it was not worth the time and the effort to register the death. And then key facilitators across the socio-ecological model again, despite these many barriers, the household narratives did reveal many conditions under which families were able to register. So again, on the individual level, if someone knew that deaths should be registered and how to do it, they would. And then at the interpersonal level, it continued. So if a family had knowledge and exposure, if a male in the family had died previously and they knew the steps, often they would try to pursue it for a female family member. And then we had perceived value and practical necessity. So this perceived value goes back to, are there any incentives? So if the female was working, there were more incentives and there was perceived value associated with it. And then we also had community support. In Tanzania, we found that village executive officers were a huge support. In Solomon Islands, these were church leaders. So these community members who had knowledge and exposure about death registration would come, and they would come to households and they would talk about it. And if this message was received, families and communities would pursue female death registration. But then at the institutional level, it goes beyond it. We've been hearing about the onus that falls on families to register deaths. But when the institution comes to the household, when these village executive officers and community health workers came to households to check in after they knew that a female died, a family would register the death. And the onus was not falling on them. It became a communal act. And then again, more quotes. So here we're highlighting what the participants saw as facilitators. So this top gray highlights the perceived value of female deaths increasing if it was linked to keeping a record for deceased family members. So this was something that was specific to Solomon Islands and Tanzania, but it was a huge value add. If you had a record of your mother's death and you could pass that to your children, it was a facilitator to register her death. And then across the countries, this huge motivator was this immediate practical need. So if you're looking at the green, you can see that it highlights that in Bangladesh, a significant motivation for registering female deaths was the need to access or even discontinue social protections. So this became a huge topic of interest in Bangladesh because people saw it as a motivator to discontinue it so someone else could get those resources. And then similarly, the bottom gray quote from Solomon Islands, for families of females who were registered and had been employed, access to and management of bankings and assets were a huge motivator. So this is employment in a formal setting. If they were working outside of a formal setting, there was no incentive again. So what are our recommendations? There we go. So our findings demonstrate that demand for registration is highly responsive to perceived utility and system design. So our key recommendations include communicating the value of female death registration beyond community leaders and simplifying the administrative processes, which goes in line with linking registration to services of value to increase uptake of female death registrations. We saw that often there was an informal system where if you just told someone that your female relative had died, you could simply bury them. You could simply get access to their bank accounts. And it wasn't with the need of a death registration that was formal and certified. And then further key recommendations, we know that strengthening gender-responsive CRVS systems requires not only technical improvements, but interventions that address social norms, including gender norms, that enhance service accessibility by leveraging those organizations and workers who are already integrated into communities to shift the onus of death registration and ensuring the confidential reporting pathways that enable reporting of gender-based violence and other sensitive causes of death. And with that, I just want to end with, by incorporating gender equity into CRVS reform, countries can advance more complete, accurate, and meaningful mortality data, ensuring that women's lives are counted. Thank you.
Thank you so much. And I was telling Alicia before, like, I'm not a qualitative expert. So for me, this is really, really different. And it's very, very interesting to see these kind of methodologies and what you can get out of it as well. What I particularly appreciate are the stories, right? They really resonate and it makes it much more alive. Also, thanks a lot for focusing on kind of the role of incentives and the role of linking to services and so on. And then the whole potential additional research area on sensitive causes of death. I think we have a lot of work to do on understanding the reporting on of those issues better. I think we can grab one or two questions if there are any burning questions around the. I'm looking around. We don't have any online. Oh, sorry, am I blind? Oh, we have 3 hands now. Okay, sorry. Glasses on, glasses off. Over here, the first row. Thank you.
Okay, merci.
Thank you very much. What I would like to know, as your study was about 3 different countries, right? What are the country specificities that you were able to see, that you were able to notice for each country? Have you seen like something very specific, where regardless if it's in the legal framework or other? Hello, good morning. As my colleague said, this study has been done throughout 3 countries. If I take Tanzania in Africa, for instance, I've been working on the under-registering of the death, and I use the qualitative approach as well. But for the woman, it can be explained that in certain types of communities, it's very cultural. Concerning women, I don't know if this is something that you have been thinking of, especially within the context of Africa. When you talk about gender-based violence in some communities, it's starting from the birth, the childbirth, when the child is a young woman, until the death throughout the whole life cycle. And I take the example also of certain communities in Chad, when a woman, there is a woman death within a household. You can only bury the body if there is a compensation that the husband has to give before the parents can proceed to the inhumation and just dispose of the body or take the body. So it's already a big break. It's already a break for the husband to declare the death. So I'm not sure if you have been thinking about this kind of practices, especially concerning Tanzania. That's my question. Thank you.
So much. I think there was a third question. Sorry, where was that?
It was the same. My question was the same as the first one.
Oh, okay. Okay, great. Okay, so these questions was about the really in-depth understanding of the cultural specificities in these settings, and whether there was something specific. I think predominantly you were mentioning cultural practices in Tanzania regarding burial practices and so on, and how that could affect the likelihood of registration. So I don't know if you want to try and respond to this. Thanks.
Hi. Yes. So every country did their independent analysis and did publish country reports. So if we want to talk after, I can get you Tanzania's country report. But I did want to mention that we did have unique findings in each country. So in Tanzania, they have what's called e-RITA, or it's a mobile registration of deaths, and that did seem to be a strong facilitator. So if families were conscious or worried about the cause of death, they often were using e-RETA instead of going in person to register a death. And they wouldn't go to cafes that were also being used as facilitators to female death registration, but they would do it online, and that seemed to facilitate more female deaths with what may be considered sensitive causes. In Bangladesh, we saw that when there were community health workers that were already engaged, and if people had exposure to and solid relationships with police officers in their local communities, that was also a unique facilitator. So the police played a role in the notification and registration of death a lot of the time, which was unique to Bangladesh. And then in Solomon Islands, the gender-based violence piece in Solomon Islands was the most prominent. So we did see it in Tanzania, but in Solomon Islands, it was mentioned in almost every interview. So we have to consider the rates of gender-based violence and intimate partner violence in Solomon Islands when we're talking about this. So their country-specific paper addresses that specifically. Tanzania's does address gender-based violence, but not as much since it wasn't as prevalent in the interviews. Yeah, thank you.
Thank you so much. We also have a comment online from one of our UNICEF colleagues also regarding Tanzania. I don't think all of you have access to what's happening online. So Bhaskar says, in Tanzania, the simplified death registration system was rolled out in 5 regions, including Iringa and Njombe, where death registration is completed in health facilities and ward executive offices in a one-step, one-visit process. Kilimanjaro still has the old centralized system. And death registration improved substantially in these 5 regions, including female death registration. So simplifying the death registration process is the key. And I think that's, pretty much sum up what we've had from our first 2 presentations already. Thanks a lot, Bhaskar, and good that you can join online. I saw several other hands. I think let's park them to later because we have 3 other amazing presentations. So I think let's go through the next presentation first. And but maybe just a round of applause for Alicia. Thank you so much. Okay, so our third presentation is from Sri Lanka, and Asanka De Silva, who's another one of our CART participants. So it's been nice to hang out with you the last few days. And she's presenting on the patterns and contributing causes of mortality differences between females and males in Sri Lanka. She's a statistician at the Department of Census and Statistics in Sri Lanka, and she specializes in demographic trends and vital statistics. And her research focuses on understanding the complex drivers behind mortality disparities between genders. And beyond this work, she's deeply interested in broader demographic transitions, specifically fertility patterns and the socioeconomic implications of populations aging in the South Asian context. So over to you. You have the clicker? You do. Excellent.
Good morning, everyone. Thank you, moderator. In most of Asia, men and women share a similar struggle for survival, with life expectancy gaps often narrower. However, in Sri Lanka, a silent transformation has occurred. Today, a Sri Lankan woman can expect to outlive her male counterpart by nearly 7 years, a survival advantage more common in most of European countries. So, why is this happening, and why are Sri Lankan men falling behind? My name is Asanka. I'm statistician with the Department of Census and Statistics in Sri Lanka. Today, I'm honored to present my research titled The Patterns and Contributing Factors of Mortality Differences Between Females and Males in Sri Lanka Across Age Groups. This study explores the widening gender gap in survival and identifies the key drivers behind these disparities. Before begin, I would like to express my sincere gratitude to my supervisors, Dr. Lisel, and especially for the Professor Lakshman Disanayaka, Emeritus Professor in University of Colombo, Sri Lanka, for their invaluable guidance. I also want to thank the Department of Census and Statistics and the Registrar General's Department for providing the data. Finally, my thanks go to UNECA and UNESCAP and the 2025 CART initiatives for organizing this research training. As an introduction, the gender differences in life expectancy are more than just numbers. They are critical indicators of health inequality. In Sri Lanka, we have seen a significant historical shift. In the 1950s, male and female life expectancy was nearly identical. However, by 2013, a wide gap of 6.7 years emerged. What makes Sri Lanka's unique is that our longevity patterns now resembles European trends more closely than those of our South Asian neighbors, who typically see much narrower gender gaps. A major factor in this transition is the rising burden of non-communicable diseases. As you can see for this data provided by the WHO, NCD deaths have steadily increased between 2012 and 2019 critically. The trend line for male is consistently higher than for females, suggesting that men are bearing a disproportionate burden of chronic illness. So my research seeks to answer these three core questions. First, which major cause of death contribute most significantly to life expectancy gap? Second, how do mortality patterns differ between the sexes at specific ages? And third, at what particular ages are these differences most pronounced? To answer these questions, I conducted a secondary quantitative analysis of all registered deaths in Sri Lanka for the year 2020. This data sourced from Registrar General's Department was combined with mid-year population estimates from the Department of Census and Statistics in Sri Lanka. I conducted all deaths with valid age, sex, and ICD-10 cause of death classification, ensuring robust national data set. My analytical framework uses two main approaches. I calculated cause-specific mortality rates per 10,000 population and going to apply Arriaga's decomposition method to partition the life expectancy gap into specific cause categories. Furthermore, I'm going to compare the age-specific mortality rates across 5-year intervals to pinpoint exactly where the greatest disparities occur across the life course. Especially, I am in the initial stage of this study, and I have mentioned here some in pink color what I have done so far, and I have to do the other stages as next stages. Until now, my results show a clear male disadvantage across all top 6 causes of death. Diseases of the circulatory system and ischemic heart diseases are the leading contributors, with male rates significantly higher than female rates. For example, the male rate for circulatory diseases is 18.2 compared to 20.5 for females. I also see a striking gap in external causes such as injuries and accidents, where the male rate is more than that of females. When we look at the mortality curves for males specifically, we can see relatively flat trend until age 24 until now. After this point, there is a sharp and a divergent increase. Circulatory diseases represented by the line accelerated most rapidly, followed by closely ischemic heart diseases and respiratory conditions in the older age groups. These charts illustrate the comparative patterns for each major causes. Note the male hump is external causes during late adolescent and early adulthood. In contrast, for these diseases like neoplasms and circulatory issues, the gap widens most significantly after age 50. This confirms that male vulnerability is not limited to old age, but begins much earlier in the working age population also. These are the results until now of my study, and when I go to the discussion. The implications for policy are clear up to now, the results up to now. And first, we need to target resource allocation, such as road safety programs for young men and cardiovascular screening specifically for older men. Second, this data help us to measure health system performance by identifying preventable deaths. Specifically, one of my objective is to identify what are the preventable cause of deaths of men in according to the ages. Finally, by addressing the structural inequalities and social determinants of health, we can implement better monitoring tools like tobacco control or specific successful close to gender inequality gap. So in conclusion, while Sri Lanka has achieved remarkable longevity, the widening gender gap requires urgent gender-sensitive health interventions. So thank you for your attention. Now I am so happy to ask any question.
Thank you so much. And I think it's very nice to see what a country that has very good registration completeness can do with that data. So it's a very nice bridge from the previous presentations as well. I mean, because you have fairly high registration completeness in Sri Lanka, we can certainly see all of these detailed patterns and start looking at that and obviously get to the actual policy implications that can avert some of these deaths. So this is really, really interesting. I'm wondering if there are any questions. I see multiple down here in the first row.
Firstly, thank you for such an interesting presentation. As I could see in your presentation that men have more mortality rate than women. Is it because of socioeconomic factors or more life risking conditions in which men are working? Is it because of that, or it is because of that maybe like the data is not correct, or maybe like women are underreported or something like that? So I would want to know your take on that. Thank you so much.
Thank you. And I think we have another question just behind there.
Yes, thank you so much. I'm Yehuta Remo from Uganda. I loved your results. Most so my question relates to what a colleague has asked. There's something interesting about external causes of morbidity and mortality. I would empower you. Do you think, what are some of the sub-categorizations do we have here? Like in our settings in Uganda, we are seeing that injuries are becoming prone. Do you think it could be one of these, or it was another kind of category that was not shown in these top 6? And I think, if so, would you think that you would maybe come up with tailored interventions to mitigate some of those external factors? Because I saw they were disproportionately showing a bigger deviation between the genders. Thank you.
Thank you so much. I think, is there a third quick question? Yeah, Yando?
Thank you. I'm Yando from Indonesia. I would like to know your justifications for the 5 out of 10,000 as a threshold, as a high risk, because yeah, that could determine which policy are you going to address later on. Thank you.
Thank you so much. So there were a few questions here. One, well, 2 of them were related to the higher mortality for men in certain age groups and whether this is linked to risky behavior and lifestyles. And I think digging a little bit further into that, our question from Uganda, whether you have looked further into these external causes that might give actually very good recommendations for policies, if this is based on injuries or particularly risky behavior. And then I think a slightly more technical question from Yando, why the focus on the 5 in 10,000, 100,000 deaths, sorry. You?
Thank you, moderator, and thank you for your questions. Both 2 questions. In Sri Lanka, male deaths, the reported male deaths is higher, and we categorize if we categorize according to the ICD codes, it has reported like that. This I have identified, and external causes have affected for especially cause of death among males, and I have identified that is as a cause of death. I think it will be, I'm going to find, but that is that will affect for the that gender gap, to create that gender gap. Until now, that these are the results that I can say. And thank you for your question. And I will find is that will be the major cause or any other causes. And for the question, in the third question, the assumption I have used for this research is if there is if the reported deaths, according to the reported deaths, I have used if death if five deaths per 10,000 population have occurred, I have used those are the major causes, because the others maybe some other categories may like, and I need to identify the major 5 causes, because to apply the technique in this research, the Arriaga decomposition method. That is my reason. Thank you.
Thank you so much. And I see more questions. I think we'll park them until we have finalized all our presentations, but we are slightly ahead of time, so we should have time for the questions later. And the next presentation is actually, we're continuing in the statistics area, but we're now starting to look not just on gender differences, but also on ethnicity. So this is even more unexplored, the gender differences in death registration. So I must admit, I'm quite excited about this presentation. The presentation is on unequal access to birth and death registration by ethnicity in Vietnam. And it is coming from our colleague, Mr. Can Tran, from the National Statistics Office under the Ministry of Finance in Vietnam. And he has over 15 years of experience in population statistics. Generally, his work focuses on civil registration and vital statistics and the use of administrative data to support the transition towards a register-based population census in Vietnam. And I know for many of the statisticians in the room, this will be something that you also would like to be doing at some stage. Sorry, we had a bit of a technical issue up here. So do you have the clicker over there and you're ready? Okay, over to you.
Yeah, thank you. Good morning, everyone. My name is Chen Khánh from the National Statistics Office of Vietnam. Today I will present to you about death and birth and death registration in Vietnam, with focus on different across the ethnic group from 2021 to 2024. Before I begin, I would like to thank to the National Statistics Office and the Ministry of Justice of Vietnam and the UNFPA and also the VS. So to start, Vietnam had 54 ethnic groups, and the Kinh group is the biggest, largest group. And the Kinh group account around 85% of the population in Vietnam, and the other group are smaller and often live in remote and mountainous area. And in recent years, Vietnam had made strong progress in improving the CRVS system, especially with the digital system. However, the national results may not show the full picture. So in this study, we will look at the difference across the ethnic group in completeness and timeliness registration. About the research method, we use 2 main data sources. The first one is administrative data, it means CRVS data, and the statistical estimate. And we analyze more than 11 million birth records and 2.6 million death records from CRVS data from 2021 to 2024. And we measure 2 indicators as the in first in the previous slide, that is completeness and timeliness. The analysis is based on disaggregation by ethnicity with a descriptive comparison between King majority group and ethnic minority group. About the results, the first national completeness, as you see on the graph, the birth registration increased from 88% in 2021 to nearly 97% in 2024. And also the death registration also increased from 87% to more than 96%. But when we using the event estimate as denominator to estimate the rate, and you can see the birth registration remain high, about 93%, and reached 97.2% in 2024. However, the death registration is lower, around 80 to 82%, and about 81.8% in 2024. So overall completeness improved clearly, but the result differ depending on the data source, especially for death. Next, timeliness. The average time for birth registration about 33 days. And this is within the legal limit of 60 days. And some delay happened because births are registered late, sometimes several years after birth. And for that, the chance is different. And you can see the red line. The average time decreased from nearly 17 days in 2021 to about 13 days in 2024. This is close to the legal limits of 15 days. It shows that the time release improve over time, especially for death registration. Now we will look at the difference across the ethnic group. Completeness also improve for own group, but not at the same level. The King group had a high coverage, increased from 90% in 2021 to 98% in 2024. And among majority group, completeness also improved, but remain lower. In 2024, same group are around 87%, such as Thai ethnic, Nung, Khmer, and Mường. Other groups are lower, such as Thai, Hmong, and Dao ethnic, at around or just about 83%. So the chance for all ethnic group is positive, but the difference across groups still remain. The difference become clear when we look at the time release. The King group had shorter registration time. Some minority group have longer delays, about 40 to 70 days for birth registration, and 30 to about 55 days for death registration. For some small group, delay can be even longer. So we also see large change from year to year, especially for small population. From these results, there are several key findings. First one, we can say that Vietnam had made strong progress in CRVS. The second one, the data system cover most events. As you can see in the previous slide, we have more than 11 million birth record and nearly 3 million death record from 2021 to 2024. But there's been a clear difference across the ethnic group. The King group had better results, while many minority groups have a lower coverage and longer delays. So the national progress is not the same for all groups. And these results had some important policy messages. First, CRVS system should focus more on population in remote and disadvantaged areas. Second, it's important to monitor data by ethnicity to see the difference across the group. Third, combining administrative data with the demographic estimate can help improve the measurement of completeness. Overall, broad and inclusive registration is essential for legal identity and reliable population statistics. Beyond this finding, maybe three main actions we can be highlighted here. The firstly, improve registration coverage among ethnic minority groups, especially in remote and mountainous areas. Secondly, use disaggregate data more actively to monitor difference and support the policy. Thirdly, improve registration service, including digital system and better coordination. For next step, more research is needed to better understand the cause of this difference. And to conclude, Vietnam has high CRVS performance at the national level, but different across ethnic groups still exist. So it's important to look beyond national average. Thank you.
Thank you so much. We are really in for a treat. That's another excellent presentation. Thank you. I really appreciate you also highlighting the issues with the data sources. I mean, when we start looking at, we're trying to measure who are not measured, right? So it is per definition difficult. And I really appreciate that you highlight those issues and the difficulties that brings in as well. It is really nice to see research on ethnicity issues because it is often kind of neglected and it's really, really important. And also looking at the timeliness is something that we are increasingly seeing, and I think it's a really important issue as well. So thank you so much for those really interesting observations. And of course, coming up with additional research. I feel like we're kind of setting the ground for another research forum in a few years. Let's see. Anyway, does anyone have any specific questions to our colleague from Vietnam? And the hands go up immediately. Okay, we have 3 questions in the first row. So let's take those 3. And if we start from you on the left, yeah, and then we'll, thank you.
Congratulations on the presentation. My name is Stephen from Zambia. I wanted to find out if you were able to do any statistical tests to test if the differences that you had observed between the different ethnic groups were actually statistically significant.
Merci. Bonjour à tous.
Thank you very much, and good morning to all, and congratulations for this presentation. I'm Mr. Deputy from Cameroon, and I'm working with the mobility. I'm very interested in internal mobility. So I would like to get maybe more information about the characteristic of the various ethnies. What's their characteristics? Because in Africa, this variable is seldom used. We use more in surveys, but it's bringing some limitation to our comprehension. Concerning the mobility, it's more to know about if some ethnical group are geolocalized, or which means that sometimes they are not able to modify the perception of things or other when it comes to the birth or death registration. So do you have localized ethnies, and do you have nomadic ethnies maybe, and other factors such as education, for instance, or the employment in a socioeconomic point of view? What kind of differences maybe were you able to notice? Thank you very much.
Thank you so much for your presentation, firstly. So my question is, sometimes in ethnic groups, more than the reporting problems, it is about trust. Most of the ethnic groups don't trust the governments or policymakers because historically in the past, the data has been misused. So how do we build trust first to include them in the system, and then later we talk about the data collection? So thank you so much.
Okay, there were 3 excellent questions. I'll try to just rephrase. The first question was about the statistical significance of your findings. And related to that, the second question, there were, well, actually second and third, there were 2 questions. One was about the other characteristics of these populations, like the education background and so on. And then there was also related to whether any of these ethnic groups have specific mobility characteristics, or whether nomadic populations. And I think generally a wish for a bit more understanding of these ethnic minorities and what characterizes them. And the last question was about trust. As highlighted, ethnic minorities in some settings face kind of historical difficulties, and trust with the majority population and the government might be an issue. So how to build that trust and ensure that they are included in data collection exercises. I hope I did your excellent questions right. It's a lot of questions. You can try. Thank you.
Yeah, thank you for the question. And firstly, I would like to say that the question is very good, very interesting, but for me it's very difficult to explain very clearly about that issue. So I can say maybe some very brief. And if you want to get more information and more understanding about Vietnam context, maybe you can interact by email or something like that. And so I can say that with the 3 of you, I maybe I can say with the generals. And the first one, you asked about statistic. Maybe if you read my paper, you can see that I use the results from CRVS data. It means that's a real record, and we combine with the national statistic survey results. And we in the survey the result we have it's like sample error or standard deviation, and we just use the results at the from the survey as denominator to estimate the rates. That's why in this survey I don't use any statistic check. And for you guys, maybe it's very long question, so I don't get every idea. And if you you say about maybe can I understand that you and her is maybe the question is almost a little bit same, like you asked about the character quite sensitive. It's like ethnic in policy from the government, and in Vietnam, you know, the government have mainly policy for the ethnic, special for very small ethnics. We spend the how can I say it? Maybe my English very different to express my idea. Almost like the government have spent many give them many support, yeah, to involve to join to the social and to the labor force market also, and you say about the church, but in Vietnam, maybe long ago, maybe that's a very big problem. But now, over time, now is that maybe I think that the problem is not very much, you know. Thank you. I hope that you can get some idea to explain your question. Yeah, thank you.
Thank you so much. No, I think it's always difficult to just understand the national context, and I think you gave some very good responses there to a lot of difficult questions. I think in general we are seeing more work on registration of nomadic populations and ethnic minorities. I think it's something we need to work more on, and I really appreciate those questions. And also this research is a nice way to bring that body of evidence further along. So we have our last but not least presenter. You want this? There we go. Okay. So here we have another CART participant. Very exciting. Raful Hassan from the Director General of Health Services in Bangladesh. And he's a medical doctor, a health researcher, a field epidemiologist, and a public health practitioner. His activities focus on improving the quality of life of people concerning equity and justice. And now he's serving as a medical officer in the Ministry of Health and Family Welfare in Bangladesh. And I can definitely agree with this. He's eager for learning, mentoring, and collaboration. And it's been very nice to have him as a CART participant as well. His presentation is on factors influencing the timeliness and completeness of death registration in Patagata, is that correct? In Bangladesh. So over to you.
Thank you. Thank you, Tania. Particularly, I am a medical doctor, and I worked in coastal regions for more than around 5 years. And this study, or the work which I am going to discuss with you, that is based on my experience. My experience grew my interest in death registration particularly. And in the slide, you can see, we all can see, a girl is crying. This 19 years girl came for death registration to a union parishad. This is the smallest administrative unit of Bangladesh. And unfortunately, she lost both of her parents around 2 years ago. And she was the single sibling. And when she lost her parents, there was no one to take care of her. Even only a little bit land her father had, she had no right of that. She stopped schooling and started working at the house of other people. And when I visited that Union Parishad, she was just about to cry. And when I asked her what happened, I am a doctor of this Upajala, she just cried out loudly. So this is the situation, how birth registration barriers are daunting people to register and get their rights and get justice and equity. I am Mohammad Rafiul Hassan. I welcome all my audience here and online, and particularly from Bangladesh, my mentors, my colleagues, those who have joined online. Good morning, good afternoon, good evening. Let's start. Factors influencing death registration in a coastal sub-district, Pathorghata, Bangladesh. We all know that death registration is a major component of CRVS. We are working for the SDGs, those 17 SDGs. But interestingly, 7 out of the 17 SDGs depend on mortality statistics. And particularly SDG target 3.2, 3.4, and 16.9 are directly involved with this. And interestingly, birth and death registration in Bangladesh started very earlier. In 1873, first act was formed, and later it was reformed in 2018 as a regulation. In the meantime, there was another act that was birth and death registration in 2004. And in Bangladesh, previously Ministry of Health was responsible for registering deaths and births. But after this act, particularly after 2018, the registration went to the Ministry of Local Government. And another office was formed that is called Birth and Death Registers Office. And the thing, what we saw from DESTA and LSA and others, that death registration is very poor in Bangladesh also. It's below 40%. And why coastal regions? There is a question. Particularly, Bangladesh is a South Asian country. It's beside the Bay of Bengal, and 19 districts shares the coastal margin. And they are the poorest fishermen in the world. Frequently faces natural disaster, schooling is very low, economy is very low, population is very high. So they face the highest challenges. My area is a very small area. It has only 162,000 people. It has 7 administrative units, unions, and a municipality. So I wanted to see how is the situation in my area, in my working area. The completeness of death registration, the timeliness of death registration, what challenges people face during death registration. And particularly, as a government official, we are deprived a little bit at a point. People think that they are not getting. We always think about the challenges of the people. But what challenges the system face, the providers face, we usually don't see that. I wanted to see that also. My method was a mixed method study. Particularly, I analyzed the secondary data first. Then based on those data, I interviewed some people. And later, I developed some themes and analyzed them. I took ethical approval from Southeast University of Bangladesh. Here we can see that death registration improved the number after a very interesting thing. That was, Cabinet issued a target for death registration in July 2024. And after that, we can see drastically improve, particularly after December 2024. So we can see here that administrative pressure can improve things. But let's see what has happened. The things happened that in 2023, the completeness was 37.8%. But in 2025, it has crossed 100%. Then where is the matter? Because the small administrative level population is not measured very well. So the denominator is not good. And there is very large effect of migration also. People migrates outwards and inwards. And what is another matter? That's the timeliness. We saw that completeness is improved, but the timeliness, which our law says we should register our deaths within 45 days from occurrence, that is not happening. Regarding seeking registration, we developed some themes. Elisa has already told some of those. So I just want to focus very small things that people faced barrier to death registration, those who have not the birth registration of the deceased person. And they think that without legal needs or without inheritance, they don't need registering birth. Interesting thing, another lies there. Even those who registers birth, they also think that this is not essential. They think that they are burdened, and this is the work of the health department. So local government has no responsibility for this. And the daunting thing is that we have digitalized, but the internet is interrupted. So people need to come so many times for registering. And whenever he or she has to close her shop, or the person, what Elisa has already told, that I have some goats at my house, but I can't go. So what we can recommend? We can recommend that we should do something like Asanka, that death registration is important. This should be utilized. And we should make people feel that this is not useless. So I request funders and others so that let's develop something, a unit that will analyze the CRVS data and will develop vitality statistics regularly, disseminate those, and utilize in policy making and inform population your data is being utilized and the data is safe. I want to recommend some more things also, that there are some mismatch of cause of death in the interface of our digital system. We need to align those with ICD-11 code. And what has already been told, that we need to communicate. We need to communicate the importance of the death registration. We need to communicate the utilization of death registration. And finally, I want to acknowledge everyone, particularly my CART team, my friends, my mentors, ECA, ESCAP, and especially Bia, Tania, Nicola, Petra, Joan, and Nicholas, who supported me a lot. I am available for everyone. You can scan the code and reach me. Thank you so much.
Thank you so much. And I didn't develop the program, but I think it is amazing how this all came together. And I really, really appreciate that you had that actual personal story in the beginning, because this is why we're here, right? And I think sometimes, especially when we focus on the statistics and the kind of higher level data and so on, we forget the personal stories behind it. So a huge thanks to you to actually bringing it back a little bit to what this means for individuals. And I guess ultimately why we are all here and trying to do something about it. So thank you. You also, I mean, your study is very interesting. It's great to see the in-depth understanding you have yourself of the system and how you're trying to bring that to others. And of course, there's a lot of different issues, data issues and so on. But one thing that you mentioned that also came up a little bit in the previous presentation was about migration and what that means for your data as well, and what that means for your understanding when people are actually moving within your data set. So many good things there, but I will not talk too much. I'll ask anyone else if they have any questions. And we have quite a lot of time. I think we have about half an hour plus for questions. So first, if we can have any specific questions for Raful, and then afterwards we'll do generic questions. I see a question here at the back. Yeah.
Good morning, everyone. Hong from Vital Strategy. Thank you very much for the presentation. And I see in the recommendation there is one talking about the develop local level denominator for robot assessment. Do you have any envision or any idea about how to make sure to obtain accurate denominator for at the sub-district level? And this question also related to my question to the first presentation in Indonesia. When one of the recommendation also about the further analysis at the sub-district level, just want to ask if you how to address this issue relating to the accuracy of the denominator number, because in Vietnam we are at the national level. The denominator we use for the complete needs is from census, from NSO, the estimation from NSO. At the national level, it's quite good, but at the lower level, it's still a lot of challenging. Yeah, thank you.
So my name is Yvonne. I'm from Ghana, and in your discussion, you said that digitalization has rather slowed the process and has failed the process. So what would you recommend that we do to improve the situation?
Okay, let's take those two first questions. So the first question was about the denominator, which is a very large problem we have in many, many countries when we're trying to look at completeness estimates at the lower levels. So what have you done there? And I think that's also a question for Indonesia later. And then the other question was about digitalization of systems and how you overcome those problems.
Okay, thank you. Especially thanks to Vital Strategy, because I was looking for Vital Strategy to ask this question. The thing is that we have some options at our hand. Particularly, Ministry of Health maintains a system that is called a Smart Health BD. We utilize this for our home visit by our health assistants. They visit house to house every month and collects information regarding their health condition and diseases, pregnancy, birth of children, and even migration. So if we can incorporate that data with the system, so easily we can develop a very good denominator for very small levels also, even up to the world of union. That means around 2 square kilometers. So it's an opportunity. And one more thing for developing the denominator is that there are some local level surveys for so many things of the government. Particularly at this moment, there is having a survey of animal survey. We are surveying how many animals are there and who are the owner and what type of animals. So during this time, we also collect the information how many members are living in this family, in this household. So we can incorporate that data also. Thank you. And I will request Vital Strategy, I have already requested Vital Strategy that when people will be willing to give this data, if people see that this data is being used for our benefit, for their benefit. So what I always want to say as a medical doctor and you can say from the very primary school life, I am involved with social work, as social worker, that you are to feel that people, that you are working for them. So I need support from Vital Strategy. We need support from Vital Strategy regarding developing vital statistics from the CRVS, from the civil registration data. And my second question. Thank you, Yvonne, from Ghana, because in this era of digitalization, we think that converting something to digital, that means everything is done. But particularly, I work with the digital health system of Ministry of Health Bangladesh, and we have already developed the blueprint for the digital health for our ministry. And what we found, that around 80% of the digital initiatives in health sector are failing, whether in business or in government. The thing is that the digital solution we have developed that doesn't match with the utilizer, the users, the clients. Clients may be two types. Those who are service provider, they are also client because they are the client of the system, the digital system, and the service receiver, service seeker, they are the real client. So when my system is not compatible, then what I need to do? I need to maintain two systems, one digital one, second the previous analog one. Like see, I have a video, if I had time I would have showed you, that I was there for around 7 minutes and the website was just loading. It's like a very old advertisement of Bangla Lion internet modem that they just downloaded the video of a lady, of an actress, and when that was downloaded, she has become old and her hair has become white from black. So it's like that. So what we need to do? My recommendation is, I have already mentioned in my slide, because I didn't just repeat, that we need two things, very good interface and uninterrupted server service. That server should not be down. Whenever people are working, they are down. What I found in my study that during 9 to 10 or 11 a.m., this works well. But after 11 a.m. or 12 p.m., everyone is hitting the server and it gets down and we cannot access. So there is solution also. Thank you.
Thank you so much. I very much appreciate you. Digitalization is not always a solution to everything. Thanks for that. I think the issue about the sub-districts and denominator, can I ask you to respond to that one as well, Desta?
Yeah, about the denominator, like I mentioned before, actually, I intend to estimate completeness of death in the district level. Actually, I propose to use a diary method that using regression method, so we don't need denominator. We just need a model, some variables, then estimate it. It's about my future research. But to enhance the denominator, actually, ministries in Indonesia, including Statistics Indonesia, trying to enhance the quality of mortality data, because Indonesia, especially Statistics Indonesia, towards registered best census in 2023. So we need the strong CRVS data as well as social economy data. And actually, Ministry of Home Affairs and Ministry of Health has a pilot activities that integrate data from both of them, like Vietnam also to do. And also there is another program from Ministry of Health, but actually right now they are focused on the maternal mortality. So they are try to focusing on maternal mortality because we don't have like sources to do extended like all the cause of death. So we hope by doing a lot of things, we could enhance the quality of the mortality. So, but yeah, it's still a long progress. Yeah, thank you.
Merci.
Yes, thank you very much. I have a question concerning I believe the second presentation concerning the variation in mortality between men and women. When we have a look at the various profiles here, we can notice that the child mortality is almost null, is almost not shown. It's starting from 40 or 45 years. So my question is the following: is it a reporting issue that we do not have the child mortality? and in the management of the information for the reason of death. It could be disease or other causes, but some are already related to the gender. For example, if it's a prostate, something with the prostate, it's for the man. If it's for the uterus cancer, it's more like with the woman. So I don't know what are the interaction and the correlation between these. So is it taking into accounting or is it separated? So even if separated, did you take this into consideration, the fact that you have some diseases that are reserved for the man and some other types of diseases reserved for the woman? Thank you.
Thank you, Jay Moderator. My question goes to the last, Dr. Mr. Hassan, about death registration. He said in his method that he has used qualitative research, one of the methods. And I would like to understand what you call the 8KII 6 IDS 2F, 2 focus group discussions. I think this is the various population you have interviewed about the aspects. And I would like to know, did you find same factors as you had done in the quantitative side? There is something that they call in the qualitative research the level of saturation. At the level of saturation means that you have interviewed as much as possible the number of persons, and the answers they are giving is just repeating itself. So there's no need to interview more. I would like to know what you have done about it. Do you think that this number of persons that you have interviewed is enough, or was enough to get the right and relevant answers or factors for these levels of registration? Thank you.
Oh, thank you so much, Moderator. My name is Richard. I'm from Lesotho. I'm here on the part of ECA as a CRVS mentor. So, Rafil, I'd like to congratulate you for your presentation. Nice one. When I go through your slides, especially on the challenge on providing death registration, I think that if the team in Bangladesh, you can have, I don't know if you have it, a committee which can involve all key stakeholders involved in death registration. This can solve some of the challenges that you guys are facing here, especially if you can also have a MOU among the different different committee that's involved. It will solve so many problems. I can see lack of awareness, but health can play a big role on that. So the community leader in the community can play a role. So that is just my input on your recommendation. Thank you.
Thank you so much. Okay, let's just try and cover these 3 questions first. The first 2 questions was about methodology. The one question was for Sri Lanka and how you have considered the specific mortality patterns of children in your study, because it looked like there were no children's death, but I think that might have been the data you showed. And then there was also a question of how you're considering causes of death that are gender specific. I think prostate cancer was the example in point. And another methodological question was for Raful for Bangladesh, basically regarding your methodology for the qualitative parts, whether you were looking at kind of saturation of responses and how you did that. And then the last question was also for you. I think that was more recommendation, and I think it goes beyond Bangladesh. I think it was a recommendation for ensuring the well-functioning CRVS coordination mechanisms across the countries to try and overcome some of these silos and awareness issues. So I think that actually goes way beyond Bangladesh. But thank you for that comment as well. So I think let's start, if you're okay to respond to that question. Okay, over to you.
Thank you for the question. In Sri Lanka, the child mortality is very low comparing other ages. And in this study, I'm going to identify what are the age stages will affect to increase the life expectancy gap between male and female. I have mentioned in my presentation the gender differences according to the causes of death reported in 2020 in Sri Lanka. Those graphs shows specifically the causes, the deaths per according to the media population in that year. Yeah, that is the answer, and those are the results according to the data reported in 2020.
Thank you, and I think you might have more questions later as well. Bangladesh, 2 questions for you. Well, one was more of a generic thing, but one was about your qualitative methods.
Thank you so much. As an epidemiologist, I am very happy that someone has asked about the methods. I really appreciate this. To be honest, I also agree with you that their saturation matters. And particularly, we have 7 administrative units, that is 6 unions and 1 municipality. So there are only 7 persons who registers deaths. And one is the person who is in charge of the Upojela. So I have only 8 people to ask. So I conducted key informants interviews with 8 persons, number 1. Number 2, I conducted 2 FGDs with the community people. One with the community people and one with the community health workers. Those work in the health department. And finally, after this, I wanted to ask the experience of the people. That's why first I asked plan for 12 people, but after 4, I found that everyone is saying same thing. That means I found saturation. Maybe it may happen because I might have not reached so many people, diversified people, because I had limited time particularly. Particularly, to be honest, I am not working in the same place. I had to take leave from my ministry, my office, and went there. And there is some limitations also, time limitations, funding limitations also. So I think IDI, in-depth interviews, could have been more. And there we could have explored more. I think we can do this. Thank you. Thank you. Special thanks to you for talking about the methods.
And just to highlight, Raful, we're also getting comments on the chat that was a very good presentation, just to let you know. And also thanks for highlighting the practical issues, like internet connectivity and so on. I think it's very practical, and I think someone meant some things many of you can relate to. Okay, so there was a lot of questions. So more questions. I am open for more questions. Let me see. Are the hands coming up? There was, sorry, over here. Yeah. Sorry, I have really poor eyesight, so we really need to, otherwise I have no chance. Over to you.
Thank you. I'm Jing Shan from China, and I have a question about the second speaker, Hancock's research. Your presentation showed that a low perceived value of female life is a major barrier to their diet regeneration. If the value of female registry is increased, for example, that is also lead to an increased risk of active harm or violence against a female in their family. If so, what's the most important first step in preventing this? That's my question.
The question was about what was the most important to prevent the lack of death registration and gender-based violence. Was that also part of the question? Sorry. Okay, let's just take another couple of questions first. Were you okay with, you understood the question? Okay, great. Okay. We'll take 2 more questions. I'm seeing a hand back there.
Thank you very much, all the participants. It was an excellent presentation from all of you. My particular question is from the lady from Indonesia. You've talked about the low coverage of death registration in the areas which are far from the capital. I was wondering if the criteria for the legal inheritance was there, and what is the percentage in the population that they would go for the death registration to have this inheritance process is completed. Thank you.
Okay, so this question was about the role of inheritance, and especially in remote areas, for incentives for death registration. We will take one more question. Over here again. Thanks.
Thank you, Chair Moderator. My question goes, I am Elvis from Cameroon. My question goes to Miss, I forgot her name, let me read. Miss Asanka. I don't know whether it is a methodological issue, but you have produced the results in your research, but I would like to know the recommendation you can give out of these results, because I seem not to have seen the recommendations, please. Thank you.
Okay, great. So now we have three different speakers. There's three different questions. The first one was for you, Alicia.
So I think responding to gender-based violence and the sensitivity around that is going to be country-specific, but I will say that across all three countries, it was noted that if there were female registrars present, that female family members felt comfortable with to go to talk about sensitive deaths. That seemed to be a facilitator to address more sensitive causes of death, right? So that wasn't isolated to gender-based violence. It also had to deal with sensitive deaths around suicide, abortion, and loss of children. I hope I'm answering your question accurately and fully. Thank you.
Yeah, and thank you so much for raising a really important issue. I mean, I've worked in this space for a very long time, and I have never seen any sort of data on the gender balance amongst registers. So I think it's something that is quite interesting to potentially look into. And Desta, you got your question? Yeah.
Yeah, thank you for the question. So actually in the East area, it is more cultural effect, like it is in Papua, so low completeness of death registration in Papua can be linked to the customary inheritance system. And in many communities, inheritance, especially like land, is managed under customary law and decided by family or community leaders without requiring official document, such as death registration. Because inheritance doesn't depend on formal registration over there, so people have low incentive to report death to the official system. So that's why they have low completeness of death registration.
Thank you so much. That's a very good explanation. And there was a question to Asanka, I think, regarding whether you have recommendations from your research. I know you're still in the process, so maybe not, but I don't know if you have anything yet.
Yeah, thank you for the question. As the mentor said, I'm in the stage of analyzing, and my recommendation is if there are reasons what are the causes that affect to make that gender gap in the life expectancy. And my recommendation is we need to focus on the men's health and the identification of the cause of death, specifically focus to the men in Sri Lanka, and we have to reduce that for the reduction of those cause of death. I think that will be the external causes, sometimes workplace-related causes, and specifically the social factors such as behavioral factors maybe, but I don't know how the exact results may be. And my recommendation is the health must be focused, not specially for the women, and as well as for the men in Sri Lanka. Thank you.
Thank you so much. I think we have time for just one more round of questions. I'm seeing a hand from Vietnam at the back.
Yeah, hi, Hope from Vital Strategy again. So my question can be considered as a comment to the presentation of Alicia. Yeah. In the background information, you provide some charts about all-cause mortality rate, but I think I would like to hear from, because in order to frame, in order to make a stronger argument for why we are research about the to strengthen the female registration, it would be good to have a chart or a number about the completeness of the female and male, the completeness of the death registration between male and female in 3 countries. Maybe the data is not available or something, or yeah, I would like to know about that. Thank you.
That is an excellent question. And I can tell you from SCAP's side, we've been trying to get an overview of just death registration completeness, not by gender, in the region. And we have managed now. The current estimate is that there's about 3.4 or 3.7 million deaths that go unregistered every year, but that was very difficult to get to. We also tried to make an estimate of that number by gender, and it was completely impossible at a regional level, but in specific countries, of course, it is possible. So, but we'll park that question and take a couple of more. But it's a very good question, and yet another huge data gap. Other questions, please. Oh, yeah, back there. Sorry.
Thank you for giving me the opportunity. I'm Parveen from Bangladesh. I analyzed the mortality data of MCCOD from 2020 to 2024 in whole of the Bangladesh. I observed a gap. Actually, the male death registration is higher than the female, but at the age group between the 20 to between the 30, it is different. Here, the female mortality is high than male. So all of you, I have a question. Do you have any observation? What is the cause? Only for reproductive age, maternal cause, or having any other issue or any other cause we can't identify? Thank you.
Thank you so much. And I think that's almost a question to all of our speakers, right? Looking at the intersection between different characteristics of individuals. It's not just about gender, it's also about at which ages are the differences and so on. So I think that's a question for everyone, I think. So everyone is ready for that one, if you've observed anything in your research. And we have another question for Amna.
I have a question for Rafael. You mentioned that in 2024, your completeness crossed 100% because of the cabinet pressure. So that means all the previous deaths over the years, they have been registered, I assume. So is till 2024, is now every death in your region registered?
Okay, thank you so much. So the last question was very specific, so maybe we'll start with that, if that's okay, Rafael.
Thank you, Amna. Thank you very much. Particularly my study had 3 phases. Number 1 phase, secondary analysis. Number 2 phase, I will do the qualitative part. And number 3 phase, I plan that I will conduct a census, mortality census. My team will go from house to house and they will say how many have died in last 2 years and how many have been registered. Particularly, I didn't get fund for the census. If Amna, you can cooperate with me and fund me, I can ensure, I can tell you that. Thank you.
And I think Rafael just highlighted how we spend a lot of the CART discussions on scope and, and getting people to focus on something manageable. Yes.
And just to be honest, that I talked to some people, particularly my community health workers. They are telling that now particularly we have a term choukidar, village police. This is like for maintaining the rules and regulations in the village level. They are under the local government, particularly the Union Parishad, which is the smallest administrative unit in our country. And there is a very inhuman thing that if they fail to complete their target, they face some challenge regarding their salary. So they are visiting house to house. They are just like searching for deaths. But particularly, to be honest, as a medical person and as a social worker, I don't support it. Thank you.
Thank you. So before we go to the question for everyone on the intersection between age and sex and other variables, there was a question for you, Alicia, about the differences in registration completeness for those 3 countries, whether you had that data.
So for Solomon Islands, we do not have that data. For Tanzania, we do, and it came from RITA, so their registration, insolvency, and trustee agency. We found that the completion rate of all death registrations, I think, was under 5%. And then when we looked at male versus female, the female rate was less than half of the male rate of completeness. In Bangladesh, I don't remember if we were able to access that data. I think we asked Vital Strategies to help us a lot, and we were never successful. So Tanzania was the only country to successfully obtain that data.
It's not always easy to get the data we want, otherwise our jobs would be significantly easier. So I think we have a question for all of you. In your research, whether you have seen anything kind of digging deeper on the intersect between age and gender and maybe other variables as well. Maybe I'll ask you first from Vietnam, since you haven't had any questions.
Yes, about the male and female days. And you know, when I heard from you that the male date is as female date higher than male date, is very surprised. You know, in Vietnam, every year I also estimate the dates by male and female, but I don't see that happen. Male dates only higher than female date in every age group. Yeah, and so to explain for what happened in your country, maybe I don't have I have no idea for this one. In Vietnam, it's only higher. Yeah, thank you.
Yeah, thank you for the question. And in Sri Lanka, the registration is almost, I think, reach 100%. Sometimes it may be changed more than 95%. So the gender difference, when considering the gender difference, the almost equal report death registration in Sri Lanka. So that may be changed the cause they have died, but the registration is very high.
Thank you so much. Alicia?
So we found in Bangladesh that social protection programs, so those of widow pensions and old age allowances, were triggers for death registration, especially in widows and elderly women. So to transfer those benefits or to stop those benefits, people would register a death. However, when benefits didn't apply, so for younger, unmarried, or non-enrolled women, those families weren't perceiving a payoff, so they didn't register the deaths. So that could be creating a gender disparity and an age disparity there.
Thank you so much. Desta?
Yeah, for Indonesia, we see the data of completeness of death registration between male and female. Yeah, male higher than female. The difference is around 10%, but we ever test it in statistical method, but the result is not significant statistically. So, and I personally, I never dive into the maternal mortality like in 20 until 30 age. So I don't have any opinion about that. Thank you.
Thank you. I think being a doctor is a very bad thing because when I want to say, I just saw the data and I analyzed on its data that in 2023, our female death registration was very low, and same things happened in every year. Like in 2023, female was 30%, male was 69. In 24, female was 32, male was 67. In 25, the female has little bit become higher, 39%, and the male has become 60%. So it was around double. Yeah, we take the gender, and that's so that I can tell this. Thank you.
I think all of our speakers were very kind to put their contact details on the presentations. As you probably should know by now, all the presentations are available online, and we will eventually also put the videos of this up after we've breathed and relaxed a little bit. We will also get the presentations up from the videos up from the forum. Before we finish, I just want to say a huge thank you to the people behind the scene, Yui and Nicola, who supported this session, and of course, thank you. Thanks to everyone. I thought there were some fantastic questions, and I think our speakers were all challenged, which is good, but they also gave us some excellent presentations and some fantastic answers to all of these questions. Please try and grab them if you have more questions, and we'll see you after lunch. Okay, thank you, everyone.